numbers, because we didn't even have a Joanne Musson. Because Tatum got sick. I told her. But Tatum got sick. Joanne.
Thank you. Good evening, everyone. I'd like to welcome you to Bermuda College to our 2025 Roche Science Week. And we're really excited to have Dr. Butler, as well as our new president, Dr. Sam, who this is his very first Roche Science Week. So he is going to welcome officially Dr. Butler.
Thank you. Good evening.
Good evening.
Welcome, and those online, welcome to Bermuda College. Before I proceed, I want to do a couple of things. One, introduce to you our first CEO of this college, Mr. Black. And it's important that we do that any opportunity that we get. But now that we are celebrating 50 years, he was there at the beginning. So thank you for being here. Okay. The second thing is that Ms. Simmons is the chair of the science areas. So please come up. Leadership for our science area, she put this together. And there's one thing, well, with the team, I recognize that. And there's one thing that I don't do with employees anywhere. I don't hug them. But in public, today, I'm going to hug it. Thank you. Why? Happy birthday to you. And so that we know, I have a personal affinity for February 12th. That's my late mother's birthday. She would have been 84 today. All the way back in 2001. And so it's a special day. Thank you.
Thank you.
And yes, I wouldn't be hugging anyone. This is a wonderful program. For the scientists, all of us have to be thankful for the sciences, because every advancement that has been made in our lifetime and well before and into the future is based on the sciences. So it's always good. Secondly, it's a wonderful program because it brings us distinguished scholars who are able to enlighten us on contemporary issues. These are the kinds of things that distinguish institutions. Here are classes to be attended, everything, but when you bring world-class scholars to your campus to talk about these kinds of topics, very, very important. And we are fortunate this evening to have someone who is extremely distinguished. See, in the academic environment, degrees are important because that's what we do. And when you take a look at these letters behind it, and I take a look at it and say, and she will incorporate some of her background in her comments. But a single thing I will say first is that she's Bermudian. Yeah. And let me see if I can get from you my second most important thing. Did you ever take a course at Bermuda College? Okay. We'll forgive her for that. But your background is extremely distinguished. And let me mention some to you. Bachelor of Science in Pharmacy. Okay. At the end of the presentation, if you have doubts about your medicine, and you are taking medication, she can ask you. And she has a Doctor of Pharmacy degree also. So she knows her stuff. She wasn't satisfied with that. Okay? And she studied economics also. And you know something? Yeah, she's good in science and everything. And then she added economics to it. All right. And then she completed a managed care pharmacy residency at Harvard Vanguard, Harvard Pilgrim Healthcare, and a fellowship in drug therapy outcomes at the University of Illinois, Chicago. When were you in Chicago?
2001 to 2003.
I wasn't there yet.
Left.
So, and the best were not doing well anyway. So that's why she could spend all her time studying. All right. And so we've taken care of the Doctor of Pharmacy. She wasn't satisfied. She went for another doctorate, a PhD degree, Doctor of Philosophy in Pharmacological Outcomes and Policy from the University of North Carolina. Go Tar Heels. Tar Heels. See, she was following Michael Jordan. And you think, oh yeah, she's in the sciences and everything. She went for a master's in business administration in addition to that. Okay. So you see all these degrees and of course, master of public health. So she knows something. She knows something. And she's going to share that something with us. I tell you, at the end of this presentation, we'll be enlightened. Ladies and gentlemen,
Good evening, everyone. I just want to thank the Science Committee, Nisha Daniels. I'm sorry, Simmons. Sorry, I knew it. She was a Daniels. I want to thank the university and the Science Committee that all selected me to be the Roche Science Speaker this year. It's an honor to be able to present and show the different work that I've done over the course of my career. So this evening, I'm going to start by just starting with a story, giving you a little bit, because Dr. Sam gave you some of it, of my background and how that webbed a thread through how I ended up doing research with using health data. And then I'm going to end with some insights in terms of what that means in Bermuda. And then after that, we can have questions if you like. So picture it. It was 2004. A high school teacher was sitting at her kitchen table, sipping her coffee, and then mid-sip, she saw a headline: Vioxx pulled from the market, heart attack risks revealed. She had been taking Vioxx for about 2 years, and it had worked for her arthritis. Prior to that, she couldn't find relief. But now she could no longer use this medication. That same person, 3 years later, saw another headline: Avandia linked with heart attack. She was taking this for her diabetes. So 2 widely used medications, both believed to be safe, were now the center of serious safety concerns, and millions of people, including this teacher, was left with a couple of questions. How long were we at risk? Why didn't we know sooner? And could this have been prevented? These are the questions that I've spent my career answering. So good evening, everyone, again. And let me tell you more about myself, and then we'll go back to that story. So my journey began, as you heard, right here in Bermuda. I was a student at both at Purvis Primary, Work Academy, and Soldiers Grammar. And they laid the foundations for me for my love for science and mathematics. But it wasn't until I reached Philadelphia College of Pharmacy where I discovered pharmacoeconomics. And this is the study how clinical care, drug therapy, and economics intersect. This was an aha moment for me, where I realized that data could be used to evaluate the value of medications, improve patient care, and shape healthcare policy. During my time, I was also introduced to managed care pharmacy, where I learned that health plans evaluated medications, not just for their effectiveness, but to also find the impact of their cost and how they impacted patient outcomes. I was hooked. So after pharmacy school, and you might not know this, but pharmacists do residencies like physicians as well, I completed a pharmacy practice residency in managed care at Harvard Pilgrim, Harvard Vanguard, and with Massachusetts College of Pharmacy and Science. This experience sharpened my clinical skills, but also gave me early exposure to electronic health records. It was the year 2000, and Harvard Vanguard just implemented Epic. Epic was not known to anyone that time 25 years ago. I saw firsthand how health technology and data could be used to improve patient care. At Harvard Vanguard, I also learned about academic detailing. This was the process where we educated physicians about their prescribing using their performance data. Since we were in a staff model HMO and the physicians were financially or at risk for their patient population, they had an incentive to actually listen and change the way that they practice because we were helping them manage their benefits. This was my first glimpse at how data-driven decisions could change healthcare practices. My next steps were a fellowship at the University of Illinois at Chicago. This is where I gained, again, both clinical experience, but also exposure to the pharmaceutical industry because I worked with Pharmacia. During my fellowship at the University of Illinois at Chicago, or UIC, it opened doors because this place was a pioneer in clinical pharmacy practice. And they positioned pharmacists to be integral parts of the medical care team. Meanwhile, at Pharmacia, I was exposed to drug therapy processes and learned that pharmaceutical companies demonstrated the value of new products to insurers and healthcare systems by looking at health outcomes related to quality of life, how much they may cost the system or save the system, and how they might save lives. Studying medication, and I also was able to study medication adherence and quality of life in asthma, because at the time, Pharmacia was looking at a drug entity in asthma and was also looking at a drug entity in heart failure. And so I had a multitude of experiences learning about these two disease states. During the time, I pursued my master's in public health because this expanded my understanding of health policy, quality of care, and health disparities. But I wanted to go deeper. So instead of going to work, which my parents would have wanted me to do, I went to Chapel Hill and pursued my PhD in pharmaceutical sciences, but concentrated on pharmaceutical outcomes and policy. At UNC, I had the opportunity to combine, again, health policy in more depth, epidemiology, survey research, and I took time to really understand health disparities and what was driving them so we could do better interventions. Also during my PhD, I convinced a company, Exenda, to fund my education in exchange for me working for them. This allowed me to get a great deal of hands-on experience evaluating cost of care, medication adherence, again, in a deeper scale. We developed consensus guidelines where there was no evidence that existed in the literature. And I had real-world health outcomes experience using claims data. At the same time, my dissertation focused on Medicare Part D, which was newly approved by the US Congress. And this gave me deep insights to how policy changes impact how care is delivered. By this point, my path was clear. I was going to use healthcare data to answer real-world questions that affected patients' lives. While I initially thought that I would go into academia, an unexpected opportunity came at Kaiser Permanente in Georgia, and that changed my trajectory. At the time, the US government had just invested $1 billion in comparative effectiveness research. And this was part of the economic recovery from the great financial crisis. This funding was aimed at helping healthcare organizations use data to improve patient care. Kaiser Permanente was perfectly poised to take advantage of this money and what that was available. They had just implemented their EPIC system across a much larger platform of regions and patients than had happened at Harvard Pilgrim 5 to 10 years earlier. They had a structured data warehouse where they could share data across the multiple regions. So I was in one Kaiser, but there were 8 other regions across the United States. And because of this new funding, they decided that they would set up a Center of Effectiveness and Safety Research so that they could leverage their numbers, again, to compete for research dollars and to improve healthcare both within the system and outside of the system. So from day one, I was writing grants because yes, that money was available, but you had to get it. And we were really successful. We got grant proposals and funding to study diabetes care in a project called Supreme DM. We had Medicaid, we had funding for asthma studies for the PEAL network. The cardiovascular network that we were part of received funds to look at the intersection of cardiovascular disease and depression. I had an opportunity to look at obesity research from a broader standpoint. And funding also came through to look at genetics and health disparities. So it had 2 studies that looked at Black populations and trying to understand how genetics may play into their severe hypertension, and also looking at how genetics may impact how women take their breast cancer medication. So I had a great opportunity and great time, and they were building my skill set in terms of understanding how to use data. I was the investigator that led the nimbleness, making sure the infrastructure was there so that we could go and participate in many of these studies. So let me take you back to the story that we started with. Remember Vioxx and Avendia? Well, the public demanded answers from those safety concerns that emerged and were wondering why it was too late. Why didn't we know sooner? In response to the outrage that was occurring at that time, the US Congress passed the FDA Amendment Act of 2007. We call it FDUP. And in this act, the FDA was required to actively monitor safety, drug safety using electronic health data. And the goal was for, 100 million people to be part of this data to evaluate drug safety by the year 2012. This was a massive shift in terms of how we would look at drug safety. Up until this point, it was mostly passive. The system relied on doctors and patients reporting their side effects. I was part of the Mini Sentinel initiative. And instead of going full throttle into this whole Sentinel initiative, the setup and Congress thought about it being a pilot first to make sure the proof of concept worked before it was expanded more globally and wider. And so this system was set up so that we could do, again, active surveillance, and we had to design a system and infrastructure that could quickly replicate signals and find out if there were issues related to any drugs and their side effects. Additionally, they also had more protocol-based studies where we might have to do more intensive methodological and statistical analysis to actually see if a relationship existed. And this is where I got the opportunity to lead very early in my career different research studies. So just telling you a little bit about the Mini Sentinel initiative, we had to build this infrastructure. While it was led by Harvard, one of the big parts was having different data partners across the US. And this was very collaborative in terms of how FDA approached this. So instead of it being completely top down, they were partners with us as data partners. So they didn't just lead, they might've asked a question because it came up, but they really relied on the experts, whether they were in methods, whether they were in different disease states, whether they were experts about the data. The approach that they took was to develop a system where each of the data partners had certain levels of data that they had in their data warehouse, and we all had a common system to make it easier for us to do analysis. Because if you think about it, different hospitals, different insurance companies, different doctors' offices, different pharmacies, they all store the data in different ways. But to be nimble, we had to have a common theme, and that resulted in our common data model. So our data models included enrollment, demographic information, all the kinds of encounters that you encounter at a healthcare system, what your diagnoses were, the kinds of procedures that you may have received. Laboratory tests was something that was newer, that was added at a later point, vital signs, and of course, prescribing. What was different about this initiative is that they didn't get any of that data. They were really consistent in terms of being, keeping the privacy of the individual's data at their home institution. So because we had this common system, they could send analysis to us, we all ran them, and we sent back aggregated data. That's just a different way of looking at it. Instead of them saying, send me all of your data, they let the data stay at home in your institution. And this kept control. Again, it had privacy that was addressed and many other issues, and it was very efficient. And this is just giving you another view of what it meant. If FDA had a question, the question was submitted out to our operating center, and then it was submitted to the data partners. One of the big things of this initiative, for anyone to actually believe the outcomes that we were finding, would to be that there needed to be great data quality. And so before we did any analysis, we spent months making sure that once we had set up that common data model, that the data was good, wasn't dirty. And so there were several different levels of checks. So giving you example and just looking at admission dates, so if somebody went to the hospital, a simple check would be, is admission date missing from the data? And then why? I know they were admitted, why is there no date? You could look to see if it was formatted correctly. Again, if you have different formats, you may be analyzing your data and not getting the results you want to see. Our second level of checks look at accuracy. Did the date happen before the person was discharged? Secondly, the integrity of it. Did it occur in that person's enrollment period? So enrollment periods are based on you being insured. It's a little bit different in the US than in Bermuda, but if it happened while you weren't enrolled, that doesn't make sense. So there's some sort of error there for us to be able to capture that data. And lastly, the third check looked at consistency. If we continue to monitor your data over time, are we seeing spikes and big changes? And if we do you understand why? But in essence, we should. Another example of this data quality checks happened at when we were looking at labs. So I mentioned that that was a new field. So up to now, if you had insurance data, you wouldn't have the lab values. You would know that a lab had been done, but you didn't know what the outcome of was the lab. So going through that process was very tedious because people enter data the way that they want to enter it. So for a lab that was just supposed to say negative, sometimes we had a dash, sometimes we had a dash VE, sometimes we had a neg, sometimes we had a negative. So we used very rudimentary at that time, natural language process techniques to try to streamline what those outcomes look like. And so that took a long time. So you're looking through hundreds, sometimes thousands of records just to make sure that it's streamlined in terms of what that value look like so we can easily use it later on. Because sometimes many of the adverse effects related to drugs were related to lab values, whether it was liver function or even renal function. So we needed that data to be consistent so that if those questions came up, they could be analyzed. One other example we had was with hemoglobin. There was a hemoglobin, which is in your blood, but then there was hemoglobin A1C. And so the value should have been milligrams per deciliter, but we saw a percentage. So that meant that the glycosylated hemoglobin, which is a measure of diabetes, was made in that field and not the hemoglobin. So again, that's the level that we went to make sure the quality of the data existed. And here's just another view of what that meant. And so at the end, you can see that there are about 900 checks that were done on an ongoing basis. And we did pretty well because we were experts, in managing our data. And so on average, you might have gotten 44 hits in terms of there being a quality issue out of 900. So that's pretty good. And then this happened pretty much every 3 months because we would be updating the data every 3 months. And they wanted to know why, and you needed to know your data. So this was the mini Sentinel. Again, I'm just trying to show that this was a thorough process that was thought in terms of making sure all the infrastructure to answer these critical questions existed and were built. So I was part of Mini Sentinel, like I said. We were a data partner. We worked hard, and we actually achieved one of the goals ahead of schedule. So if you remember, I said that Congress required that we had made 100 million lives by 2012, but we hit that mark in creating that data prior to that in 2011, a year early. So now that this infrastructure is built, what did we do with it? The first large study for Mini Sentinel was to evaluate saxagliptin. It was a diabetes medication that had just been approved on the market. So this is all in 2010 while we're getting ready for this. Saxagliptin was approved August 1st, 2009. Now, just because it's approved doesn't mean that it's readily available for the market. But anyway, we were prepping to do this active surveillance for this drug. We had to, we had to figure out how we were going to do this analysis. When you have new drug therapy, it doesn't mean that everybody is going to be on the drug. So you might have small numbers. So how do you handle small numbers? Additionally, we have small numbers. Additionally, there are people that have different risks. How do you measure or manage the different risks that can happen with persons that have are taking these medications? We needed to make sure that we were using the appropriate comparators. Because again, Avandia put a big shadow on what it meant to have new diabetes medication and for the fact that such a large number of people had the disease. Additionally, we also had to look at the outcomes. So there was a lot of work that took place in Mini Sentinel to establish how we were going to measure those outcomes in electronic data. Prior to that, you would have chart review and go through and read notes and determine whether somebody had a heart attack. So all the adverse outcomes related to many drugs were pressure tested by researchers and experts for a mighty long time. And that ended up with us having a publication in our own version of PDS, which is Pharmacoepidemiology and Drug Safety. So 300 pages were dedicated to showing the public and other researchers what we were doing in Mini Sentinel. Because again, this process was supposed to be transparent and above board so that it could be critiqued at all stages. And so for that first one, again, because Avandia and there was this uproar about diabetes, we put our protocol in and really make sure that we could measure what we needed to measure as time went on. So it took a while. There were many revisions because you learn you learn different things. We had about 50 persons that were part of our working group and had different roles. I was part of the core because at Kaiser Permanente, one of our lead researchers was an expert in diabetes. And again, this was an opportunity to stand up and put my hand up being part of the core team. But other than that, we had groups that were looking at methods, groups that were looking at endpoints, groups that were experts in cardiovascular disease, groups that were experts in diabetes, and we all worked together. And interwoven into those groups also were persons that worked for the FDA. So what did we find with saxagliptin? We had about 82,000 people that actually finally took that product. It had to ramp up over time. We made sure that we had the appropriate comparisons. And we had 18 different health systems that submitted data that were part of this process. We used techniques and statistical modeling called propensity scores to make sure that we're comparing similar patients. Again, the clinical aspects go into this as well, not just being that you have data, but certain drugs had contraindications, and we had to make sure that we did not have the different people in those buckets together. So we had all these little pieces and levers that we had to account for to do this analysis. Then there was continuous monitoring of this for over 5 years. This was our proof of concept that it could work. At one point in the beginning, we thought that saxagliptin was possibly increasing the risk of heart attacks. But as time went on and we accumulated more data and the samples got larger, that signal disappeared, demonstrating how thorough we were and that long-term monitoring was crucial in understanding medication safety. So unlike a one-time study, this research again had to continue over 5 years. Every few months, researchers analyzed new information as it came along. And this ongoing monitoring helped us understand, again, medication safety in an active surveillance process. So FDA decided that it also wanted to determine what else they could use this big infrastructure for. What other value could they get out of it? So this was an opportunity for them to look at how the impact of their policies changed prescribing patterns. And again, I got the opportunity to put up my hand. I have been working in the PEEL network that looked at pulmonary disease. And because my background in policy, those two blended well for me to be positioned to be a co-lead of the LABA review of the FDA's 2010 policies. So the issue with LABA was that there had been many studies. I'm gonna have to go back. The issue with LABA was that the FDA decided in 2010 that they were going to take a more bold step in terms of their policies related to this medication. Over the years, we were finding that persons were dying from severe asthma exacerbations who were on LABA. And the issue with it wasn't that the medication worked. It did. It was when persons were taking LABA by itself out other controller medications. So FDA had put out this advisory in 2010 to say that there were going to be label changes. So every drug has a label, and that's giving you the instructions on how you should be using that drug appropriately. But also that no one should be taking LABA by itself. And that if you finally had more controlled asthma, that you should step down therapy, including stepping off the LABA. So did it work? So they came with a question. And they were like, well, let's look right before 2010 and look after 2010. But again, I had my hand up. I was very familiar with the asthma space. And I said, you've been doing advisories since 2005. If we look at that period, we may not, only 2009 to 2011, we may not understand the full impact of what actually had gone on. And you may not get the true understanding of what your policy did. Additionally, there were changes in clinical guidelines over that time period, and some precedent studies were actually published. So a longer look back period was advisable from my standpoint because so much else had happened in this space. They agreed with me. And so instead of just looking at 2009 and 2011, we look back to 2005. We use a technique called interrupted time series. Again, you can have data and you can plot it, but you need the statistical techniques to actually analyze it. This is a technique, again, I'm working with people who are pharmacoepidemiologists, but interrupted time series is often used by economists and econometricians because it helps us evaluate policy. What was different in this place and why we definitely needed to do the interrupted time series was because this was a federal policy. Everybody was exposed to this policy all at once. So to do a before and after caused a lot of bias, and you would miss a lot of information. Additionally, I advise that we should look at all asthma drug therapy because of the impacts. How are people changing prescribing because of your alerts and your policies around LABA? They agree with that as well. So what we found was that you had different breaks over time, that the trajectory of reducing LABA use did go down, but it didn't happen just because of the 2010 policies. It happened sooner, and we could see that decline. We also saw how people were uptaking the medications that they wanted. So we wanted LABA to be in combination, not alone, and you saw the uptick. But again, it wasn't the 2010, it was some of the work that was done prior to 2010. So again, the way that you do your analysis lets you get the right answers. So after LABA, so again, these were some of the major works that I did with Mini Sentinel. Mini Sentinel continued on for another 5 years, and it showed that the concept worked. And it was at that point where the funding was given to expand to the full Sentinel initiative. This happened after I left Kaiser Permanente, but again, it's just showing the process where you need to build it, do a proof of concept before you expand further. Today, the Sentinel initiative is much larger. It has about 300 million lives in the data sets across all the data partners. It has expanded in terms of who are the partners that look at innovation and other aspects of drug therapy safety. They even have now moved such that they are looking to expand to other global countries around the world in terms of how they can do active surveillance. So I look at that program as a success. And as a small Bermudian, it's nice to see that I was a part of something that was so big that just grew to be bigger. So I'm going to change a bit and talk about another way that we can use health data. So again, we were at like the country level. We're going to take it down to a systems level. How can we use data in health systems? So in different systems, especially if you're a health plan, you have quality metrics, and they could range the gamut from things for diabetes to how do you care for the elderly to how well a patient's taking your medications, because those health plans are actually responsible for those persons in their care. One of the metrics for HEDIS, which is how health plans are evaluated, was for asthma medication. How well is your patient population taking their chronic asthma medication? Studies prior to this would say that about 50% of people were taking their chronic asthma medication appropriately. So how do you intervene? That number is far too low. Is it that the doctors aren't prescribing it? Is it that the patients aren't taking it? So this led to some research that I did with the Peel Network around primary noncompliance or primary adherence. And this was a new area because you needed to understand if a medication was ordered to know if they never got it. And before the advent of the medical records, this was hard to do. But at Kaiser Permanente, we were well positioned because I had the physician data, and I also had the filling of prescriptions in our system. So we had a comprehensive integrated system. Others may not have had that because they didn't have the medical records or they didn't have the fill data. So how did we study this and get this done correctly? Being that I was a pharmacist, I understood the behaviors that happen at the prescribing level as well as at the person level. So we couldn't just say we're going to link the data and move on. We had to really figure out how well could we measure the connection between the two. So this went into looking at how long of a period do we want to say that person is non-compliant? Do we want to give them 1 week, 14 days? Do we want to give them 1 month? We landed on 1 month, but there is other things we had to look at. If we didn't see that the person had filled it within 1 month, why is that? Could they have gotten samples from the physician so they did not need to fill the medication right away? So that had to be assessed. Could they have had a change in dose and they were using up their prior medication until it ran out and then they would fill? And then lastly, did they just have some other medication and their physician said, use it till it's finished and then you can switch to this one? Additionally, while our system was integrated, there was the odd occasion that someone could go outside our system to fill their medication. So we had to go and do a validation check by looking at the claims. So we can capture that we didn't see it in the system because they went outside. And how do you make that connection? And so again, these aren't just simple things that you just do, but we had to go through that process and I built a framework on how we could do it. And it was expanded outside of my Kaiser region to the HMO research network that I was involved in, as well as our CESA network. And so that policy stood so that all of our groups may work together, would be doing and measuring this outcome the same way. So what did we find? We found that about 20% of people are primary non-compliant. So if you multiply 20% by 50%, maybe about 10% of people with asthma take their chronic medication the way that they should. And so so we needed to understand, because now you can target what your intervention needed to be. Before, we could blame the physician, we could blame the patient. But in this instant there, we knew that we needed to intervene at the patient level and understand, why aren't you even filling? If you look in the middle, we also look at regular adherence, which says, did you fill it once and did you continue to fill it again? That's the data that we were used to from claims, but this was a new way to look at who's not getting it at all, not just who is stopping, because you could have a reason to stop, but to not start, that again required a different level of intervention. So again, these are the ways that you could use health data to answer a different question. Not there yet. All right. We're not there yet. And then I'm going to give one last one, and this is a smaller example. But I'm using this example just to show how now we can get it to the patient level. So again, with health data, it just allows us to be a little bit more efficient. One project that I worked on in obesity, and again, I'm showing you dating the time because now the new medications that are out, this process is not used as much. But we wanted to look, we had a network looking at obesity. And at that time, everything was about bariatric surgery. So there was a risk calculator created by a different physician researcher that was called the obesity mortality risk scale. And they had calculated and weighted it and said, well, this is what your risk could be. We decided to look and determine whether that risk score was applicable in our patient population. So he had done it by chart review. They were being prospective because they were at bariatric centers, whereas us, we were just a regular health plan or regular medical group, but we wanted to understand what was happening in our population. So the reasons for collecting the data were different. And we were wondering, how nimble could we be if we just used our data versus having to intentionally collect the data and calculate the risk score. So our model worked well. There wasn't much changes. But the point that I'm trying to make here is that just because you see a model and a risk score in one space does not mean it translates, because you have different population. I didn't mention this, but in our population in Georgia, we were very diverse in terms of having Black and white persons, and we could do a lot more health disparities research. So again, understanding that people have different disease risks that sometimes are seen through ethnic groups helped us to understand that we could still use that risk calculator in our population. So again, you can take that big data to again make decisions at the bedside about how you should proceed in different health procedures. So what does that mean for Bermuda? What does that mean in Bermuda? So I've heard over the years that Bermuda has bad data. I don't think any data is bad. The question is, do you know what to do with it? Do you know how to analyze it? And a group was commissioned some work about 10 years ago with a health plan in Bermuda and compared our data to data in the UK. And what some of the findings that they found were that diabetes patients in Bermuda used less labs that we would use to evaluate a person's care than in the UK. So again, there were insights that were found from that. Now the discussion was kind of light. I might have asked a different question. So if we have less lab use in Bermuda, my question next would have been why? And if you go back to looking at this and how I talked about the primary non-adherence, was it that the physicians weren't ordering the labs? Or was it that the patients weren't completing them? And again, when you ask that question, you have to get different interventions. So if I look from a patient standpoint, the labs were lipids and the labs were renal function. And that's kind of disturbing when you see that number and the disparity there for the fact that we have such high chronic kidney disease in Bermuda. You would think that we might be over sending our patients for those labs. But why? We didn't ask the questions. But again, through data, that can show us where we need to look. So was it that they couldn't make their fasting lab because they work, they have kids, the times for fasting labs was just not convenient for them? Or for the kidney function, If you're like me, you already voided when you went to the doctor, right? And so you're like, oh, well, I cannot pee. So how do we collect that data source afterwards? How do we tell patients and get them to understand how important it is? So solutions could be, do you have different times for labs? Should you use a different lab that you can get the same information but doesn't require that person to be fasting? These are the insights that we can get with the data that we have now. But the question is, do you know how to do it? Some simple things, instead of, again, saying they're bad, could be, how many people in your population do not touch the health system at all? That's another insight. The question would be, why? How many GP visits does a person have each year? Why? If you see a certain aspect of your population that seeks care but another one doesn't, is it their work schedules? Is it the type of work that they do? So again, there are many insights that we can get with the data that we have today. I know there are initiatives to do big things, to join our data together, but let's start with what we have and build on that because it can give insights to what should be done next. So again, we do have data, we just need to know how to deal with it. But in Bermuda, there are certain areas where we do not have data. And so we're going to get into this one, and I hope this works. So do you know what that sound is? Can somebody tell me? That's Bermuda College?
Trying to clear out our air.
I play that for you because for years we just didn't know, right? So how often do we encounter or we deal with symptoms that we don't understand why they occur and we do not seek medical care for them? So after many years of being very irritated with that song, finally learned that it's related to allergies. Okay, so how do you know when to take your medication? Now, in the US, they have pollen counting systems. In Bermuda, we don't. So it's easy for us to say, why Bermuda doesn't measure pollen? We can always get down on ourselves, but I'm going to show you a video next to think about it. So why is this important? Seasonal allergies affect about 40% of people. They can result in asthma exacerbations if they also have asthma. It can just make you feel lousy, leads to a lot of absenteeism from work, and just people, even if they're at work, not functioning very well. I would often have people come to the pharmacy, often around the end of February, beginning of March, but this is because I started to see patterns. But at the time, you never know the pattern right away. And they would come in and they were like, I just feel awful, it just hit me, and just sneezing, coughing, whatever. And they're like, but I don't have COVID. After a couple of patients coming through, you're like, this is happening often. Oh, it was a little bit warm last week. Oh, I do see the flowers might be out. I think you have allergies, but they don't even know that they have allergies. So again, there's a data gap here that if we were monitoring, we might be able to prevent symptoms. So in the US with the pollen counts, you kind of know at the low end because they report them every day of the weather, and then you can see peaks. When I'm going to show a video of Atlanta, but when I was in Atlanta, I used to run with a friend and I knew she had allergies. And I'm like, oh, you need to start taking your medication because we've got 2 weeks and we're going to see that peak come. And some of the best medications take 2 weeks to actually work. So this is why people might feel lousy, because if you're taking them as soon as the symptoms hit, they're not going to kick in for another 2 weeks. So let me go on to this next one here. And this is where I had to give Bermuda grace. So, oops, that didn't work. So here's what it can do for you if you do have that information. And this is an So again, when I learned that, how they do it, I had to give Bermuda grace, right? So maybe we did explore it and just realized it was too expensive. But the point in showing this is that when we do have symptoms and we find that we aren't getting the information that we need to be curious and explore, like, what could a solution be? Right now, for the fact that they're studying AI to help us identify pollen in Atlanta, there are also systems in the UK that are just started to do this research as well. So what could that mean for Bermuda? We can leapfrog the process, right? So instead of having that laborious, expensive process of hand counting pollen, we can be piggybacking on these kind of issues or these kind of technologies to get our information. Why I think it's more important in Bermuda is because we don't even know what's in the air. At least in the US, they can tell you if it's ragweed, if it's pine, if it's cedar, if it's weed, if it's grass. We have different plants. So what is it? I've been hearing anecdotally, haven't had a chance to look at the data, but people have been telling me their experiences have changed over time. So they may not have had any symptoms when they were younger, but as adults, they're experiencing it. I'm not saying you have adult onset asthma, but again, there could be another issue. So for our environmental science people, do we have new plants in our environment that we did not have a long time ago? So these are the sciencey piece where you can start to say, well, what's in our air so that we can tell you and understand what you might be allergic to. Additionally, climate change. So they mentioned it a bit there, but with us, like, we don't even really have seasons. So are you hyper allergic all year round? When does this happen? You know, we see the poinsettias usually bloom in September, but last year they bloomed in August. So again, climate change is making those seasons where they're blooming in our exposure to these pollens are actually even longer. Do we even know that our grass, when it grows and if it costs? So anyway, the point of this, Peter, was to say there are data gaps that we have. They're not always in our healthcare system. But again, do we raise our voice to complain or to say, what are we going to do about this? If I've seen something in another jurisdiction, I can always say, why don't we have it in Bermuda? But if it is coming down to cost, is there a new solution? So for students who are entrepreneurial or want to do more investigation in science, where are those gaps? Can you explore that when you go to university or college and figure out how you can solve some of the problems that exist in Bermuda by making them efficient with new technology? So where are we going with all of this? So I talked about big systems and what you can do. I talked about how you can use data at different levels, and even talked about how data can be helpful if you're interacting with your physician at a personal level to make specific health decisions because of your risk. I would say that to the different levels, there are different ways of how we can assess data. Yes, I had big systems that I talked about in terms of mini Sentinel. We don't need anything like that in Bermuda. But what you can take about that process is the methodical approach to how you identify a problem, you do the planning, you create the system for you to measure so that when you do make a change, you can say whether or not that change actually was effective. From a health plan level, let's do more with our data. Some may be, but it's not always public, but it would be helpful because we can learn more, not just using your data to do cost models. Yes, that's your business that you have to do that, but that data can be used to help improve the health of the persons that are in your plan. From a provider level, let's start looking at our data. Let's look at our performance. Let's not be afraid of our performance, because our performance may say that we needed to do more, or may say that we are doing well, but at least we know that we're serving our public the way that we should. From a patient standpoint, yes, you can read, but you have to go to greater sources. I want you to question when you go to the doctor and they make decisions about you. Should you be looking at and asking questions, is this medication or is this treatment that you're giving me evidence-based? If they say no, the question would be why? What is it different about me? Being that we're in ethnic groups, we have groups that say they want to look at one guideline versus another. If they're adamant about the guideline that they choose in terms of how they give your care, a question could be, am I represented in that guideline? So you can like your guideline, but if I'm not represented in it, why are you using it on me? So just again, being curious, reading, and not being fearful to ask those questions, because the data exists. How are you using it to help you? So thanks.
Any questions?
I feel very grateful and privileged to have, been in this lecture today. I know where you work, we work together, and I see you in different level of interactions, but I've never known exactly what you're doing in hospital right now.
That's not what I mean.
I mean, you are unacceptable for Bermuda, which is a great thing. And I'm curious of if there are any studies or research that currently are doing, and if there are, what are your restrictions or?
So I am not doing any studies in Bermuda. I wouldn't mind doing them, but again, it's a matter of where the gatekeepers are and them being willing to let the data be used. So that's the key issue.
Do you think we will have some level of leverages, being that we have the electronic medical record in place right now, in terms of connecting the gaps and dots with the community physicians, the ordering? I was just talking to a friend yesterday, and she said, I've been having this cough, and I finally went to the doctor and they ordered me antibiotics. Okay, did you ask why the antibiotics? No. I just thought that it would help. Have you started taking them? Yes. Red flag. It's just like, just having that standardized care. And
I agree with you. So again, going back to 25 years ago, being at the Harvard Vanguard, we had a big push, again, from the academic detailing. So we would look at our data and look at what was happening. And we would see a lot of antibiotic prescribing. I'm not saying that happens here, but we did a big campaign on educating the physicians that most of the times that the patients are coming to see you is viral. And so what was happening was that the patients were coming in for a visit, and if they left with nothing, they felt like it was a waste of time. So the one intervention that we had back then was that we created, it was kind of corny, but it was back then, we created education pieces around viral infections versus not. And then there was a coupon piece on this documentation that we gave them, so that they felt like they left with something, and they can still take that to the pharmacy and say, I need to get X. So we would give them symptom relief medication. So again, it was trying to fill that gap where don't make me pay for a visit and then you just send me home. That feels wasteful. So that was one intervention that we had done back then. So again, they felt like I left something, you heard me, and you were taking action related to what I'm going to do, not just making me make those decisions on my own. So we'll see what happens with the medical practice. If you heard me say multiple times in the speech, I kept on saying epic, epic, epic. And I like epic. It's a little bit different from the one that we have. So it's not as nimble, but I do understand that epic costs a lot of money. So
Yeah, I think that's the reason we all were going for Epic. When I got to training, it was Epic in the States. And when we heard the comparison, I was like, yeah, definitely Epic, when they told us to choose. But at the end of the day, again, it comes down to a lot of people are moving from EMR to Epic. So
I was talking with
it's the start for us.
Yeah, so it's a decision that people make. I was talking with in a health system in New York, and they're taking all 39 of their hospitals and moving them, and it's going to be a lot of money. It's going to be $2 billion, but
In the long run,
but we have those hard decisions to make, right? So you have a limited number of resources and have to figure out where you're going to put them.
Hi, Melissa. Great presentation, but just to speak to you as a former teacher, I didn't have a clue what you were saying up to about halfway. And the rest of the audience, no, don't be sorry, because you're not, let's say, a teacher. But you are, though, I mean, we could see just what kind of work that you were doing. A Bermudian, you were in your, how old were you in around 2010 and all?
It's not.
You could have just done some simple things to show us. I saw your name on all of the studies that you had, a bunch of names, and Melissa Butler was in their names. You know, simple things like that to let we ordinary folks know just what you were doing. But I loved your conclusion. You know, the last 15 minutes of the conclusion. I think that allowed us to really get on board. And having Bermudians come back and demonstrate their capabilities is so important. So I thought we might have even more people out here tonight. Yeah. Oh, yes. Fine. And what I was going to ask too is, what is Epic? You guys were just talking about Epic.
It's an electronic medical record system. It's a company. Like I said, when I was 25 years ago, they were
That's AI. That's AI.
they were just this little small company, and they bloomed into being one of the biggest, actually, most of the largest company that has medical records in the US. I would say because it's easier to use, but that's just me.
Yeah, but hey, beautiful. Thank you very much.
For your presentation, I enjoyed it. One thing I always think about when I go to get medication, I'm quite sure but feel the same way. The writing on the medication, sometimes you cannot read it. I think it needs to be
On the
large.
label.
On the box.
Okay.
The labeling is like you cannot make it out.
And so we did work on that too. So a long time ago, and CVS actually changed their model. So again, this was a while ago, trying to figure out a better way for it to be readable for persons who may not understand or be able to see the instructions. And like the CVS's and the Walgreens ended up changing how they did the labels, so there was more space for information. Many of the pharmacies certainly used this one system, and it would be for that system to change the formatting so that we could see it in another light. But maybe that's something for them to bring up to the vendor to say, how can we get better labels so that they could be easier to read? But that was a line of research that took place a while ago because we wanted to minimize why someone may not be taking their medication correctly.
Hey, Melissa. Remember you from St. Paul's Anglican Churches. I'm so happy to see you here and making this presentation. I just had a couple of questions. First of all, what do you think about having having more data for patient education, because I think as a nurse, a lot of times, I see patients are so depending on what their doctor tells them instead of doing the education for themselves. I think we need to probably get more data out there so they can understand that they can make an informed decision. So that's one question. Like, what do you think about how we can get more data out there in Bermuda, especially so patients can make an informed decision? And my second question is, do you think that there's going to be more research about how medications impact cultural differences or people in different cultures?
Okay, so for the first one, I think it's our culture, right? I'm so used to integrated systems, and you are responsible for your people. We have quality metrics that you need to be accountable for. You have regulations that you need to be accountable for. And part of that makes you competitive as an organization. And so if you're having these issues and poor outcomes of your population, it's your responsibility as an organization to improve them, because I have the power of my feet, right? So I'll give you an example. In Georgia, at Kaiser Permanente, we for years had to contract for the state employees. And they decided that they were going to leave because we were more concentrated around the Atlanta metro area. They left. They didn't get the service that they had at Kaiser, and they came back because there are numerous education pieces. So like I said, even when I was at Harvard Pilgrim, we created the pamphlets so that the physicians could give to the patients, or they were given out at the pharmacy. And again, because it's a system, we're very fragmented here, so no one takes the responsibility of the whole patient. Some of the insurers start programs, but I don't know how in-depth they are. And so those are kind of the issues that you might have. But I guess if one is questioning more, and we have to mature society that we're not taking offense to questions, because it is your care, right? So you have a right to your care. And sometimes culturally, we look at that as being, not behaving well. Right? And so I think part of that is the patient side, and we have to collectively decide that it's a health plan's responsibility or not to try to get that information out, because ultimately, if we're not doing well, it increases our premiums. So your second question was on drugs. So there are two ways to look at this. So I did talk about the fact that I did some work in genetics. So I had a boss who was gung-ho about genetics. Gung-ho, gung-ho. It was going to solve everything. And I'm a skeptic, right? So I'm like, I don't think so. I mean, I know drugs, but I need to understand this a little better. And prior to me working at Kaiser, we had this great pharmacogeneticist out of University of Chicago that came to our school. And I'm like, I keep on hearing all of these CEs, and they're talking about the genetics this, the genetics that. And I asked him, I'm like, is it what we think it is, or is it hype? And I'm going somewhere, so I'm not saying it's hype. And he said that sometimes we get so hooked on new technology that we forget our basic or our foundation. And so he would often get referred patients because they're like, I can't figure out what to do with this patient. I think you need to do a pharmacogenetic screen on this person. And as he reviewed what they were doing, he's like, this person has a polypharmacy issue. It's not a genetics issue, right? So you can't just jump there. The other part that I would say, and again, this is the researcher in me. So while I was going to CEs back there, we were talking about differences that you would see in warfarin and some of the other medications. My question was, if you do see a polymorphism in, say, a Black population, and that means that your genetic material is slightly different, right? So it should be one way, and yours is slightly off. Does that make a clinical difference? So you can run tests, you can see variations across groups, but the responsible thing after that is to say, is it clinically significant, right? So if I have enough data, I can make something statistically significant, but is it clinically significant? So again, remember, I dealt with large data. If I have 1 million people, everything is going to be statistically significant. I can say that the difference between you and you is 1 milligram of mercury for your blood pressure. But clinically, 1 milligram of mercury doesn't amount to a hill of beans. So again, what are you finding with that information? The other piece, when you would hear clinicians back there, and they're like, oh, well, I know that they're Black and they're going to have this polymorphism, so I shouldn't put them on that medication. That's not what that information meant, because you never did the study to determine if I move you from drug A that might be first line, meaning that's the highest level of evidence, to a second line medication, am I setting you back? Or were you better off if the first line medication, but maybe at a 20% haircut? That requires a clinical trial. Or that requires large data to help us to understand if the difference occurs. You just do not decide, oh, well, I'm going to take them off, because the comparison of what that meant does not exist. And so my fear back then was like, are we going to set people back and cause more disparities because we're jumping at the fact that we see differences and not understanding what those differences mean?
Thank you for that. Thank you.
Melissa, would you tell them the story about what was that drug around 1950 that was diagnosed, was causing some serious diseases? And it was a woman who found that out. A lot of children were born.
Okay, so thalidomide.
Yes.
So drugs. So I can't tell you the full story, but
Just,
thalidomide was used as an anti-nausea medication in pregnant women, but we didn't have the data back then to understand that thalidomide caused birth defects. Right. So many people and children were born without limbs because they were exposed to thalidomide in utero. So to prevent things like that from happening now, we have pregnancy categories. They do clinical trial, not clinical trials, they do trials in animals to try to see if there's a teratogenicity. That's what it's called when you have a side effect related to a drug in utero. But the interesting thing, when you're pregnant, yeah, sorry. But the interesting thing is that drugs get a new life, and the thalidomide came back and is used in cancer. Right, so it has a new use. Somebody restudied it and tried to figure out what it could be used for. So again, selective populations may not be well, but they could have different uses, just like certain things we don't give to children, but we may give in adults because of the impact that it could have.
All right. Apparently we have questions.
Oh, I was wondering if you could see.
Yeah, it's the same question over and over. So someone wants to know, have you come across any use of large data sets to start a U.S. age library to address multi-drug resistant bacteria?
So I deal more with person data, but that data probably does exist, because I would believe potentially those who do microbiology could be calling their data together so that they can assess that. I do know that there was a recent drug that was approved for multi-resistant bacteria, but I don't know what data that they pull from except for clinical trials. So it probably does exist, but because it's more lab-based type of data, that's not my area.
Okay.
the last point. What you could raise is the fact that overuse of antibiotics is causing X, Y, and Z.
Yes, and so we do know that, and that's why that example I gave you where we gave them the pamphlet and the coupon to go get symptom relievers instead of them leaving a prescription for an antibiotic. So that was the gist and the reasoning behind that we needed to stop that behavior.
Any more questions? Okay.
Thank you.
Well, I sort of agree with Mr. Butler. I love this real world example, and I know you shared this with me, so I was excited that you showcased it. But yeah, if you see the publications that Dr. Butler has been associated with, like how many pages of publications? I mean, numerous, like this thick. So I have to say, without giving our ages away, but she has inspired me for 45 years. So where did we meet? Nursery, St. Anne's Nursery in Southampton. We attended St. Anne's together, and then she went to Purvis, I went for Royal, then we reunited at Work Academy, but she has always inspired me. She's always been a thinker and very passionate. I always thought you would go into law. But thank you so much for enlightening us. I hope you guys learned some new terminology. A quiz for you. What is pharmacoepidemiology? What does that mean? You got to leave here knowing that word.
PBS.
Hmm?
PBS.
Yeah, what does that mean?
Journal.
What does that term mean? I need you all to know that before you leave this room.
Study of patterns of medication, whether they're outcomes, whether they're positive, negative. And there's tracking, there's trends, just like you learned a lot about epidemiology during COVID. Is taking epidemiology and looking at it specifically in the impact of medication on people.
We have a quiz next week on it. Thank you so much, Dr. Butler. I would just like to acknowledge the president of Roche Bermuda, Ms. Larondi Harrell. She's just going to say a few words, and they are our corporate sponsors for the last 30 years. And 30 more to go, right?
Good evening, everyone. I'm just going to speak very quickly. So thank you very much, Dr. Butler, Work Academy as well, but I did physics, not biochem. So I am currently the president of ROCHE Bermuda, ROCHE, in the Blue Diamond. So when you go into pharmacies and you look behind the counter, that's where you will see our brand on medicines such as Avastin and other things of that sort. We have been incorporated with the Bermuda College for the last 30 years. We built the science labs, formerly the Quran Science Labs, now the ROCHE Science Labs. And we do sponsor ROCHE Science Week, where we fly in a Bermudian research scientist. I just want to get all the words in, as well as we sponsored students here to do their studies for the 2 years of Bermuda College. So to connect between Dr. Butler and what we do at ROCHE, her data and the things that she researches and studies are so important because ROCHE's new thing is personalized healthcare. So we would take data that Dr. Butler has produced and the results of that, and then we'll come to you and say, well, sir, this is the data that aligns with you. And so instead of giving you the generic #1 used cancer medicine for lung cancer, we're going to use the data, look at your biometrics, look at your culture, the things, your environment, everything that creates you. And actually, we will give you a different lung cancer, one that will be more susceptible to you and your body that can help you to possibly be cured quicker. So that's the shift that's happening right now worldwide, where we're taking data from fantastic scientists and we are creating personalized healthcare. Thank you for all the comments as well, because such as label size and things of that sort, we are invested in that as well. Anytime someone mentions anything, we actually have to note it and document it and send it to the head office. On this label, some people cannot read it. They have to then analyze it, study it, and see what they can do to change it. It's about making healthcare good for you, the patients who are our customers. Personalized healthcare, that's the shift that we're going in. We have also supported Dr. Weldon. I actually kidnapped her, flew her in so that she could help save Bermuda from COVID. But since that, we've moved on and we're studying genetics for population and collecting the data of people so that we can determine what medicines will be better for them. So we're collecting data around the Caribbean, including Bermuda. We're collecting data around, I'm actually going to Nigeria next week, Nigeria, Ghana, and other countries where the data has not been captured as effectively and efficiently as in other countries such as the US and Europe. That way, we can then be able to apply and present you with the data that is more personalized to you. So I want to thank Dr. Butler for all of her work that she's done over these years. I did not meet you at 45 years ago because I'm not there yet, but I do remember you from Warwick Academy. And of course, Anisha and everyone, also the other professors that went to Warwick. We had a great time there. So I thank you all for coming and supporting Dr. Butler, those of you online as well, and for supporting ROCHE Science Week. We appreciate you and we need you to make Bermuda and the healthcare system better for us. Thank you very much.
Okay. Yes.